for being here today. I'm Navneet Singh, your host for this webinar. I know that today's topic might bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And to present today's topic, I welcome Professor Dr. Divya Aggarwal. Welcome, sir. Over to you.
Thank you, Navneet ji. Welcome, students. Good evening. So, my topic today is recent advances in ENT. We have already covered some topics. So, that was the first lecture. Now, this is the second lecture that we are coming through. So, the topics we intend to cover in this lecture are basically the recent advances in cochlear implants, regeneration of hair cells in the inner ear, possibilities and challenges, stem cells and its uses in ENT, and electronic nose. So as I told you last time, so if you go through your textbooks of Scott Brown and Cummins, you will get a whole section of recent advances. And you can go through those topics. They are given in a very lucid manner. There are summary boxes. So I won't be covering those in my lecture because that is available in your textbooks. What I'll be covering is either those topics which are not there in the textbooks or topics which are given in the textbooks, but they are in such a scattered manner that it might be difficult to get hold of that topic as a whole. So we start off with recent advances in cochlear implants. So cochlear implant is no more a recent advance. It is even in our country, it is here for the last 20 years or 25 years. And worldwide, implants have been there for the last, say, 35 years. So the cochlear implant technology is changing a lot in the last few years. And we will be discussing the recent advances in the cochlear implant technology. So what are the topics that we would be covering in the recent advances in cochlear implant technology? First of all is the expanding criteria of cochlear implants. So if you go through the earlier editions of Scott Brown or Cummins, the criteria that you may have found, there are few criteria, many criteria have been added. And these are known as the expanded criteria for cochlear implants. Then we will be going through the topic of bilateral cochlear implant, hearing preservation in cochlear implantation, electroacoustic or hybrid implants. Mind you, there have been questions in DNB on hybrid cochlear implants, hearing preservation in cochlear implants. So all these, most of the topics that I will be covering today, many of them have been already given to you in DNBs, in DNB exams, sometime or the other in the last few years. So then improved electrode to nerve coupling, modulus hugging electrodes, cochlear implantation for unilateral deafness, totally implantable cochlear implants, and then minimally invasive and robotic assisted cochlear implants, and lastly, integrative drug delivery system. So these recent advances in the cochlear implant technology we will be covering in this lecture. So expanding criteria of cochlear implants. So cochlear implants in less than 12 months. See, when to start with, the Food and Drug Administration USA in 1990 gave the approval for cochlear implants in children who were greater than 2 years. Then in the year 2000, they gave the approval for cochlear implants for children who were greater than 1 year. And now the current 2020, now the FDA has given cochlear implant approval for doing cochlear implantation in children as low as 9 months, and in Europe and in many Western countries, even in our country, cochlear implants are being done earlier than 9 months also, say 6 months, 5 months also. So you all know that earlier you do the cochlear implant, the better will be the speech acquisition of the child, because the neural plasticity, you know, declines very fast in say from 1 year to 5 years, the neural plasticity would decline. So the earlier you implant, it is a very basic dictum that the earlier you implant, the better it will be for the child, in the sense that the child will be able to develop speech and language. So reason why the younger age, one of the reasons why implant is being done in the younger age also is because newborn hearing screening is being implemented, especially in the developed world. In our country, unfortunately, in the general population, there is as yet no newborn hearing screening, a universal newborn hearing screening because of want of resources. But even in the institutions, children who are born in institutions, generally they go at newborn hearing screening. And as I said, that better speech outcomes, better speech and language outcomes is the biggest gain of doing cochlear implant at the lesser age. So as of now, FDA has given the approval for cochlear implants for as low as 9 months. Then bilateral cochlear implantation. I'll be discussing that in detail. So bilateral, this is one of the expanding criteria for cochlear implants. Then cochlear implants in prelingually deaf adolescents. See, earlier the dictum was that if the child has crossed, say, 5 years or 6 years, then the implant surgeon or the ENT specialist would say that now speech and language acquisition would be difficult. So, though the child would gain in terms of sound awareness, but speech and language would not be possible if the child is more than 5 or 6 years or 7 years of age. But gradually this is changing. There have been a lot of studies. So it has been found that people who are on cued speech, they they would benefit from a even in the adolescent age, even at the late age of say 12 or 13 years of age. Of course, the results would not be as good as it would be if you are implanting a child, say a 3-year-old child or a 4 or 5-year-old child. But what this means to say is that you should not refuse a child if he has crossed that 5 or 6 age barrier just because he has become an adolescent. And another thing is, in this, I would like to say that, see, if the child is not developing speech and language, suppose in case, because every child, every adolescent you implant may not develop a speech and language, but but still, the child would have a sense of hearing, a sound awareness, which is a very important part. Uh, 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 but it is a basically sound, as you know, is a protective reflex. So if a child is implanted, at least he will be uh, aware of the environmental sounds. And as per the research, many of the adolescents who have got an implant, even at an adolescent age, have developed speech, maybe partial, maybe defective speech, but some speech, or many adolescents have even got good speech. So cochlear implants are also now recommended in the prelingually deaf adolescents. Now, cochlear implantation in unilateral deafness. See, cochlear implants in unilateral, I'll be discussing this later on in details. So in unilateral deafness, if you remember, you might have also advised some patients that a patient who has come for a hearing aid, say with a unilateral deafness, you might have advised that it may or may not be successful, because the reason being that the brain may not be able to integrate the natural hearing sound from the normal ear and the, say, if you are using a hearing aid, the amplified sound which is coming out of a hearing aid. Same thing for cochlear implants. But no, now research is showing that the brain does not have a problem in recognizing or integrating the sound of the normal ear with the sound, the electrical sound of the cochlear implanted ear. Then unilateral tinnitus, it has been, of course, in our country, there is I don't think many people would be doing that for tinnitus, but then that is one of the expanding criteria for cochlear criteria for comprehension. And auditory neuropathy spectrum disorder. Now, what is auditory neuropathy? Auditory neuropathy is basically, uh, you must be knowing, it is basically a person who is unable to hear, uh, who has got a normal OAE. When you do an OAE, it is normal. That means the outer cells are normal, whereas the the when you do a BERA, you won't find the waves. Why does it happen? There are a lot of, it is a very big spectrum. That's why it's called a spectrum disorder. But in one line, basically, it is due to the asynchronous discharges. There is a problem in the impulse transmission along the eighth nerve. So the dictum is that if the OA is fail or refer, that means there is a defect in the cochlea. Only then you go for a cochlear implantation. But auditory neuropathy spectrum disorders are also being cochlear implanted. Of course, the results are mixed bag. That means some patients are benefiting, some may not. So next I come to the topic bilateral cochlear implantation. Now this is a question in itself, which has been given in the DNB exams many a times. What are the advantages of binaural hearing? So what is binaural hearing? What is the advantage? Better directionality of sound localization. So in the horizontal plane, suppose if you are crossing the road, so whether the the car has given a horn to you. So suppose if you can't look towards that car, you are also a blind person. Suppose. So if you have got unilateral hearing, you won't be able to understand whether the car has given the horn, the sound has come from your right or your left. Whereas if you have got a binaural hearing, there will be a directionality of sound localization will be there. Then the better speech perception in background noise, head shadow effect. So what is head shadow effect? Head shadow effect is that when a sound comes from one direction, it will travel to the ear to the from travel to the ear which is directly in that direction of the sound, and in the other ear the your head and your torso will act as a block towards the sound. So there will be a little bit of gap between the sound you hear. Suppose the sound has come from the left side, there will be a gap, small time difference between the sound which will travel to your left and to your right. This is the reason, this is the thing which gives you the directionality of the sound. Directionality of the sound is because of this time delay, that short millisecond time delay. And then binaural summation and squelch effect. So, sorry, I forgot to elaborate upon the better speech perception background noise. This is also connected to the squelch effect. So if you are in a noisy marketplace, and if someone is talking to you, you will have difficulty in hearing if you have got a unilateral hearing. Why? The reason is that if there is a binaural hearing, the sound from the one ear which will hear the speech and the other ear which will hear the background noise will be centrally sort of summated, and you can differentiate between the speech and the background noise, which will not happen if you have got a unilateral hearing loss. Then binaural summation, this is important. So एक से भले दो, in Hindi say they say एक से भले दो. So that you have got 1 year, and if you have got 2 years, naturally there will, especially in the case of cochlear implantation, because there are limited number of ganglion cells which are getting stimulated in 1 year. So if you do a cochlear implant on the other side, both of them will sum up and it will give a better effect, better hearing effect, and that will in effect, that will give you a better speech and language development to the child. Now, how does this bilateral cochlear implant help? Already I have answered the question in this earlier section. It is the advantages afforded by the binaural hearing, the 3 points I mentioned above. Then it doubles the number of functional electrodes and the spiral ganglion which is stimulated. See, how does the cochlear implant work? You will insert the electrode into the cochlea, and then what does the electrode do? By electrical stimulation, it stimulates the residual spiral ganglion. So the spiral ganglion may not all be functional. So what it does is that if you have done a cochlear implant on both sides, so one will sort of complement the other. One ear will complement the other. And then bilateral stimulation compensates or fills up for possible frequency gaps. See, there might be, as I said in the earlier thing, there may be islands of hearing loss. Some in some areas, the ganglion cells may not be functional. In other areas, the ganglion cells may be functional. So there may be islands of hearing loss. So one uh, island of hearing loss of one ear will complement the other ear's island of hearing loss. So bilateral stimulation compensates or fills in for possible frequency gaps of contralateral ear. Now, hearing preservation in cochlear implantation, this is coming in a big way in the recent past, and the question that arises is that uh, which hearing are we preserving in if we in a case who is severe to profoundly deaf. So there is always some residual hearing. We are preserving that. And why do we need to preserve that hearing? If we are doing a cochlear implantation anyway, that is for better hearing results by combining the natural residual hearing, usually the lower frequencies, and the electrical stimulation of cochlear implantation. Now, that I will cover in the next section of hybrid cochlear implants. Now, hearing preservation. What causes the post-implant residual hearing loss? We said that we are trying to preserve the hearing by some means, by some electrodes or some technology by which the hearing, residual hearing is being preserved. But the question is, what causes the post-implant residual hearing loss? See, when you are inserting the electrode into the cochlea, there is always some sort of trauma within the cochlea, in the scala tympani, into which we are inserting the cochlear implant. So what insertion trauma happens? There may be a fracture of the osseous spiral lamina. There will be disruption of the basilar membrane. There may be tearing of the lateral spiral ligament. All these have got a bearing on the preserving the residual hearing. Then shock waves in the perivelum fluid due to implantation, acoustic trauma because you are drilling. So the drill is also transmitting some sort of vibrational energy and acoustic energy to the inner ear, and that may cause an acoustic trauma to the drilling due to the drilling. Then loss of perilymph and disruption of the inner ear fluid hemostasis, loss due to inflammation, oxidative stress, and apoptosis. Basically, when you are sort of inserting the electrode, there will be some sort of an inflammation and oxidative stress within the cochlea, and this may cause the residual hearing to be lost. And then intracochlear fibrosis and neoossification. So when you have inserted the electrode, there may be after some time some sort of cochlear fibrosis and neoossification will set in, and that will have an effect on the residual hearing. So how do you achieve the hearing preservation of residual hearing by doing a cochlear implantation? So main thing is the electrode designs. Now slimmer and shorter electrodes have come. So they are less traumatic when you are inserting it into the cochlea. Then the hybrid implants I will talk to you later on. Then soft surgery techniques. Then there are certain techniques. If the cochlear implant surgeon takes care about that, so there will be a minimal electrode insertional trauma. And what is that? The most important is slow insertion. So if you insert it in a very rough and in a very fast manner, you will be giving, because it is a very delicate structure. The cochlea, the scalp tympani is a very delicate structure. So you will be sort of damaging the whatever the hair cells are present there. The residual hair cells are present. You will be damaging that, and that will cause a insertional trauma. So it is recommended that you do a slow insertion, take up to 30 seconds to insert it, and then use of steroids. Steroids, when you have opened up the round window or the cochleostomy opening, if you inject some steroids, it is said that they may have some effect, beneficial effect on the remaining residual functioning hair cells. Now, next we come to the electroacoustic hybrid or hybrid cochlear implants. This is a very important topic for you. See, what happens is, what is a hybrid cochlear implant? Basically, it is the a combination of a cochlear implant and a hearing aid. This number two, labeled number two. This is the hearing aid, and this is the cochlear implant. So we have combined the two. Now, why that is required at all? So if you are given a cochlear implant, so why give a hearing aid also? The question arises. So it is because of this kind of a pure tone audiogram. If the patient has this kind of a configuration in the pure tone audiogram, this is the best suited. The best implant suited is a hybrid cochlear implant. Why? See, what happens is, as you know, these are the lower frequencies and these are the higher frequencies. So the higher frequencies are taken care of by the basal turn of the cochlear, and the lower frequencies are taken care of the apical turn of the cochlear. Now, in the lower frequencies, the individual has already got almost a normal or a near normal hearing, or a hearing which can be aided with a hearing aid. Whereas in the higher frequencies, you find that it's a severe to profound hearing loss, and that may not be benefited by a hearing aid, and that will require a cochlear implant. In such cases, you need a sort of a hybrid sort of a cochlear implant, a combination of both the implant and the hearing aid. So you have unfurled the cochlea here. You can see it is 2.5 turns tube. Now this is a straight tube. You have unfurled it just for the sake of your conception. It has been done in this diagram. So what is done in this is that there is a modified electrode array. I said in the earlier section, in the hearing preservation, that shorter electrodes have come. So you see that this is a shorter electrode. So it is only covering the basal turn of the cochlea. It is not going up to the apical turn. Why? How this will help? It will this you need a cochlear implant for these higher frequencies. So your stimulation by the cochlear implant is in the higher frequency, that is the basal turn. In the apical turn, that is the lower frequencies, you don't need a sort of a cochlear implant because the hearing loss is not that acute. That function will be done by the hearing aid. So combination of the two will help you. And why one question that may arise in the mind is that even if we are using a hearing aid, why not give an implant electrode which is going up to the apex? The reason is that if you give the electrode, the electrode length up to the apical turn, there will be some insertional trauma, and whatever residual hearing is there, that will also be lost. So hearing aid will not work. So that's the reason why shorter or a slimmer electrode is being used to just cover the basal turn, and the apical turn is being, because it has got low frequency loss, that can be benefited by a hearing aid. So this is all about the electroacoustic hybrid cochlear implants. So these are implants which are both a cochlear implant as well as a hearing aid. Used in cases of individuals with severe to profound high frequency hearing loss. A short and slim electrode is used which just covers the basal turn of the cochlea, the area which is responsible for the high frequency hearing. The electrode falls short of the apical turn of the cochlea, the area responsible for the low frequency, as I demonstrated through the diagram. This helps in preserving the low frequency residual hearing. These low frequency areas are served by the hearing aid component of the implant. So what is the net result? Electrical stimulation of cochlear. You know that cochlear implant, how does it help? By the electrical stimulation of the ganglion cells. So electrical stimulation is combined with the acoustic stimulation. How does hearing aid work? By amplification of the sound. So that is acoustic stimulation. So it is an acoustic plus electrical stimulation. In short form, you will find even in the journals and textbook, it is called capital A plus capital E. So now next is, see, electrodes are coming in a big way. Electrode designs are coming in a big way. They are being sort of individualized for the individual need of the subject, of the candidate. So one such modern advance, it's not modern, rather it's a year for the last 15 or more years. Nucleus Board brought out the nucleus freedom electrodes. So what is that? That is the improved electrode to nerve coupling devices, which is also called perimodular electrode design. See, this is a cross section or through the cochlea, through the cochlea where you are inserting the electrode. So this is the lateral wall of the cochlea, and this is the sort of the modulus or the medial wall where all these ganglion cells are. So ideally, in a normal sort of a electrode, what happens is that the electrode goes along the lateral wall. So the distance between the lateral wall and the ganglion cells is so much. So naturally, if you can reduce this distance to this much, so it is much nearer to the ganglion cells. So the electrical stimulation is expected to be better as compared to when it is placed farther away from the ganglion cells or from the modulus. So what are perimodular electrodes? These are pre-curved electrodes. Basically, they are pre-curved. So this is the contour advance. This is basically brought out by the nucleus company. So it is a pre-curved electrode. So what happens is that when you have inserted it, it will just hug the modulus. It will hug the modulus. It will be near to the ganglion cells, and the electrical stimulation will be better. Whereas in the slim state or any normal electrode, why slim state only? Slim state electrode, I will say, it is the, as I showed you in the previous diagram, in the previous diagram, this is the normal electrode, the state electrode. So it is farther away from the modulus and the ganglion cells. So these are pre-curved electrodes such that when inserted in the cochlea, they are in the perimodular position, such that they bring the electrode contacts very close to the spiral ganglion cells, which are our target of electrostimulation. Now, this is again the cross section through the cochlea. This is basically the perimodular electrode design. You can see this is the modulus. These are much nearer to the modulus as compared to the normal electrode, which are so far away from the modulus, from the ganglion cells. So perimodular electrode, optimizing the electrode to neuron interface. What does it do? It basically optimizes the electrode to the neuronal interface, that is the spiral ganglion interface. So it is achieved by minimizing the distance, as I showed you in the diagram, and the distance between stimulating electrode and receiving neural cells groups or the spiral ganglion cell. What are the advantages of these kind of perimodular electrodes? It lowers the energy requirement. So because the electrical stimulus will not have to travel that much of distance to stimulate the spiral ganglion, then more discrete neural population stimulation and less trauma during insertion. What is the disadvantage? The disadvantage is it is more expensive than the normal electrodes. Now, cochlear implantation for the unilateral deafness. As I said earlier, that the prevailing sort of thinking was that if a person has got a unilateral deafness, if you give him some sort of an aid, whether in the form of a hearing aid or in a cochlear implant, so the prevailing impression was that the brain may not be able to integrate the normal sound of the normal ear from the aided sound or the stimulated sound of the hearing aid or the cochlear implant. So, but now the research is showing that electrical stimulation of cochlear implant does not interfere with speech understanding of the normal ear. Now, for this also, I have again in my earlier slides, I have told you the problem with unilateral deafness is difficulty. This I need not go back again. So basically, unilateral deafness, the research is showing that even if you put a cochlear implant in the normal ear, it is not interfering with speech understanding of the normal ear. Now, this is still in the research phase. It has not come in it is not commercially available because there are a lot of problems with this. These are totally implantable cochlear implants. Now, see, what happens is that in cochlear implant, there is a external device and then there is an internal device. This is an external device and there is an internal device which we put in through the surgery, which we implant through the surgery. So in conventional cochlear implant, there is a separate external component which consists of things like the speech processor, the microphone, the magnet, the cable, the ear hook, the coil. So these are basically the outer things. So this has got a cosmetic repercussion, as well as it makes it unsuitable for certain environments like water sports. So if you are a cochlear implantee, naturally you will have to open your external speech processor and then enter the water, because though the implant companies say that they are waterproof for everything, but generally people will not enter their cochlear implants. And during bathing or sleeping also, it is cumbersome and there is an issue with visibility or osmosis. So, but what are the limitations of that? What are the limitations in giving a totally implantable cochlear implant? So it is sound processor upgrade. See, you get every 3 or 4 years or 5 years, there is a the the sound processor, the speech processor will either need an upgrade. It will not have stopped working, but generally, even in the government sector, in the government allows an upgrade of speech processor every 3 years. So, if you want to upgrade, you will have to then again go for a surgery, take out the old speech processor, and then give the again implant a new speech processor if there is a totally implantable cochlear implant. So then faulty external wire. So if the external wire goes faulty, or the sound processor becomes faulty, or transmitter coil becomes faulty, then again you will be in a trouble, because then you will have to take out, get it repaired, and again surgically place it back. Then battery should be rechargeable, leak-proof, compact, safe, impact-resistant, and minimal heat production. Sound processor should be small so that it is not visible in the profile of the skull. It should be energy efficient, and device failure due to component failure or battery expiration. Then last comes the integrated drug delivery system. There is now a growing interest in direct pharmacological application for reducing or even reversing neural tissue loss. This is all experimental. It is not available commercially or clinically. It is not available. Surgical is not available. So how does it help? Because as I said, when you insert the electrode, there is an intracochlear fibrosis or ossification leading to loss of spinal ganglion process during population during electrode insertion. So if there is an integrative drug delivery system by steady infusion of anti-inflammatory or antimicrobial therapies, this may help the insertional trauma and the other issues related, or even reversing the neural tissue loss or reversing the neural problems. Next, we come to another field of research, which is still it is in its infancy. The regeneration of hair cells in inner ear, possibilities and challenges. See, cell division does not occur in the ears of mammals following loss of hair cells. Hair cells are the basic unit of hearing at the microscopic level in the ear of humans and mammals. So, mammalian cochlear hair cells do not have the ability to spontaneously regenerate. Cochlear hair cells are very sensitive and become damaged easily and die easily due to old age, things like old age, acoustic trauma, ototoxic drug, other traumas, and genetic disorders. Cochlear hair cell damage is the cause of irreversible sensory neural hearing loss. However, there is an evidence for limited capacity of regeneration in vivo. In vivo. And one potential means to induce hearing cell regeneration is by triggering proliferation of cells in the organ of body through manipulation of regulator of cell cycle. Now, this is the main area of interest where the research is being targeted. So, just a little recap of the anatomy of the hair cells of the inner ear. Organ of Corti contains which is basically the transducer of the hearing system. So, in which the sort of acoustic energy is converted to the electrical energy. So, it consists of four basically units: the hair cells, which are the inner and outer hair cells, which do not have any regenerative capacity. Then supporting cells, the Hansen's and the diator cells, which have got some regenerating capacity. And then there is the basilar membrane and the tectorial membrane. So, what is the difference between inner hair cells and outer hair cells? One row of inner hair cells, these are the inner hair cells, and these are the outer hair cells. So there is one row to every one row of inner hair cell, there are 3 rows of outer hair cells. 95% of neurons of auditory nerve are connected to the inner hair cells, and only 5% to the outer hair cells. Now, inner hair cells bear the major responsibility of auditory sensory inputs to the brain, whereas fine tuning of the sensory inputs by contraction relaxation is done by the outer hair cell, and this helps to alter the tectorial membrane, which will further help in the hearing process. And then the basically inner hair cells are our sensory receptors, whereas the outer hair cells are basically the efferent receptors. Now, what are the character of hair cells in humans and other species? In humans, first of all, we all know that in the newborn, the cochlea is fully mature. So, hair cells are sensitive to oxidative or traumatic stress, causing, so even if there is an oxidative or traumatic stress, it will cause cell death. So, hair cell death occurs due to, as I said in my earlier slide, old age, acoustic trauma, mechanical trauma, toxic drugs exposure, or genetic diseases. Now, mammals, as I said in my other slide, have a limited hair cell regeneration, and hair loss is irreversible. Supporting cells, as I said in my earlier slide, the diaper cell, etc., have got a can regenerate. Now, this is very much in contrast to the non-mammalian vertebrates or fish, amphibians, birds, who can regenerate their inner hair cells. And so, even if they become deaf, they can recover from deafness due to their hair cell loss. So, basically, the research that is happening is also sort of scientists are seeing whether this kind of a model can be replicated in humans or not. So, what are the current treatments for hair cell loss in humans? You all know hearing aids. If there is a partial hair cell loss, that naturally there will be let's say, moderate loss or at the most a moderately severe loss. So, hearing aids, you can use hearing aids. And in case the hearing loss is severe to profound, that means there will be the the hair cell loss is huge. Then you could use, because then the patient would have a severe profound hearing loss. You would be using a cochlear implant. What are the possibilities now for inducing inner ear hair cell regeneration? First of all, is stem cells. Whether embryonic or adult inner ear stem cells can differentiate into inner ear hair cell. This is being researched. Now, use of gene therapy, use of atonal homolog 1 or match gene delivered by some viral vectors can contribute to, this is being researched, can contribute to inner ear hair cell regeneration in mice. And use of neurotropic factors. Neurotropic factors are which will help in the nerve generation. These are animal experiments with brain-derived neurotropic factors and neurotropin-3 gene therapy against spiral ganglion neuronal degeneration. But this may have got some adverse effects. So this is basically a recap of the earlier slides. So I shall not go through it. And so in conclusion, currently the possibilities to regenerate hair cells of the cochlea as a treatment for deafness still appears to be a distant prospect, but progress towards it has already started. Now, next I come to electronic nose. About 3 years back, I think, or 2 years back, in the DNB theory paper, there was a question of 4 or 5 marks on electronic nose. So you should know this. So what is electronic nose? So as the term is, it is an electronic. It is electronic, and what does it do? See, what is your nose is doing? It is doing breathing and it is doing olfaction. So does it do breathing? No. Does it help in olfaction? Yes. It is basically a electronic olfactory device. So it is an electronic sensing device intended to detect odors and flavors. So flavors basically, are basically a subset of odor. So if you can smell something, you will also have the flavor of it. It comprises this electronic nose. It comprises of 3 parts. One is the sampling system. Then I'll come to the diagram also. We'll make it things clearer. Then an array of chemical gas sensors producing an array of signals when confronted with a gas, vapor, or odor, and an appropriate pattern classification system. What is it used for? It is used for identification, comparison, quantification, quality evaluation, maturity detection, and species identification in uh, fruits and vegetable testing. Secondly, in terms of medical diagnosis, the electronic notes as is research is continuing for that is a cutting edge diagnostic method for early detection of some diseases. Some early detection of some diseases may be possible with electronic notes. Then data storage and retrieval. See, the third component is an appropriate pattern classification system. Then it is connected to a computer which can store the data. So if it is if it has the electronic nose has sensed a rose, the smell, the odor of rose, it will stay in their storage. If it is of a sandalwood, it will remain in the. So later on, if you give a sample of say rose, so it because it is there in the data, so it can be retrieved, and the system would be able to identify that this is rose, this is sandalwood, and this is something else. So it is used to it only gathers small amount of gas exhaled by the human body. The electronic nose can capture the various odors contained in it through bioreceptors. Subsequently, form a chemical atlas is processed. And sensors based on different chemical detection principles and various electronic noses have been used in clinical disease diagnosis application. So this is basically a sort of a electronic nose, the sort of framework or the of an electronic nose. See, here is the sample through which that these odors are getting emitted. So odors, via molecules it travels, and here is the sensory array, which can detect what odor it is. Then this comes the pattern recognition system, which will identify whether it was a odor of a rose or it was sandalwood or lemon or orange or whatever. So how does it work? As I said in the diagram, sample delivery system. Sample delivery system, this is the sample delivery system. So it enables the generation of a headspace of the sample or volatile compound for analysis. Now, what is headspace? Headspace is the volume of the vapor or gas above the sample. So this is the sample, and this is the headspace. The odor that is coming out. This is the headspace. So what does this sample delivery system do? Basically, it enables the generation of a headspace of the sample or volatile compound for analysis. This system then sends this headspace into the detection system of the electronic node. This is the detection system, the sensory, which contains the sensors. So the detection system consists of a group of sensors. The reactive part of the instrument. When the sensor comes in contact with the volatile compound, it causes a change in the electrical characteristic of the compound. And next comes the computer system. Whenever the sensor senses a smell, a specific response is recorded, and the signal is transmitted into a digital form. So this is a small diagram of how the electronic nose is different from the human nose. So this is the odor, it goes to the sensor array, the signal transducer, and then the pattern recognition. Whereas what happens in the human beings, then there are the olfactory receptors at the roof of your nose. It will take the impulses to the olfactory bulb and then to the brain, and then you smell. So next, last section of our lecture is the stem cells in ENT. This you will find in many of the textbooks also. So what are stem cells? I'll be very short and brief. I'll say details you can study in the textbooks. I think it is given. Stem cell chapter is there in the Scott Brown as well as in also. So stem cells are undifferentiated or partially differentiated stem cells that can differentiate into various types of cells and proliferate indefinitely to produce more of the same stem cells. What are the types? There are the embryonic stem cells, the adult or tissue-specific stem cells, and then there are the induced pluripotent stem cells. So what are the embryonic stem cells? These come from the embryos that are 3 to 5 days old, also called the blastocysts, having 150 cells. These are pluripotent stem cells and can divide and become any other type of stem cell, and these are very versatile and can be used for any diseased tissue or organ. Then the next is the adult or tissue-specific stem cells, also known as the somatic stem cells. These maintain or repair the tissue in which they are found. They are found in adults as well as in children. And these, will you find these adult stem cells? In bone marrow, adipose tissue, and next comes the induced pluripotent stem cells. These are cells that have been engineered in the lab by converting tissue-specific cells such as skin cells into cells that behave like embryonic stem cells. So, induced pluripotent stem cells are critical tools to help scientists learn more about normal development and disease onset of progression. They are also useful for developing and testing new drugs and therapies. This is a very complicated diagram. I should skip that. And last is uses of stem cells in otolaryngology. Please consult your textbook. There are details in it. In short, I am just telling you it is tissue engineering for uh, nasal replacement. Then it is a separate point, regenerative medicine for otological application. I have sort of clubbed these two together. Basically, tissue engineering for nasal replacement, then regenerative medicine for otological application. Basically, uh, it can you can if you have lost your auricle, you can auricular reconstruction can be done, uh, and also for the regeneration of the inner and middle ear structures can be done by using tissue engineering, uh, tissue engineering by stem cells. Then tissue engineering for craniofacial reconstruction. Craniofacial reconstruction allows for restoration of facial symmetry and functional architecture of a speech, breathing, and mastication. Regenerative medicine for laryngotracheal replacement. The majority of work in laryngotracheal tracheal injury, the tissue engineering has occurred in tracheal replacement and with limited work being performed in the larynx as well. Besides tissue engineering, the stem cells are also being used as a possibility for sort of repairing or regenerating uh, the eighth nerve and the facial nerve. So that will be all for today. So, Navneet, so if there are any questions, you can take that.
Thank you very much, Dr. Dev. Trainees, you may type your questions, comments in the chat box.
So, how do I approach the chat box, Navneet? So, this is the chat box, I think. I don't think there's any question. Is there any question in chat box?
Not yet.
I think I have finished a bit early today.
No, you finished on time, sir. Just
The only thing I can say is, see, recent advances is a big ocean. There are all my DNB friends who are doing DNB or the students who are doing DNB, please, uh, you would be going through your textbooks like Cummins or uh, Scott Brown or Stelmaran or Shambo, but please be aware of whatever new are coming, because I have been able to touch only a few points in my previous mm, in these two lectures. So in my last lecture, I had given you a list of journals or books where you can find recent advances. And it would be a good idea to go through them, make your notes so that before the exam, you can revise them. Remember that in recent advances, if you can answer properly, it gives a very good impression to the examiner and you score good marks. So now I can see a question that what are the limitations of electronic nose? So limitation of electronic nose, basically see electronic nose is a device which is basically for sensing the smell and recording or storing it. So limitations, actually, I could not understand your question. Limitations means it is basically nothing to do with the human nose. It is basically a sort of a commercial. It has got its use in the uh, commercial field. And medicine also it is coming because early detection of some diseases can be done by sort of testing the breath, the odor that is being emitted in the breath of an individual. But that is in the very infant stages now. Electronic larynx we have not covered. Electronic larynx is also not a recent advance in that way because it is here for the last 20 or 25 years. So, and we have not covered, you can refer to your textbooks for that. Please restrict your questions to whatever has been discussed today, because otherwise it will be a sort of a free for all. I won't be able to answer everything because then the discussion will go haywire. So if you have got any suggestions of any recent advances that need to be covered, it can be covered by any other speaker at some other point of time. But okay, so someone wants to know the usage of electronic nose once again. So can we do that, Navneet ji? Can we go back to the screen? I think I'll go back to that diagram.
Yes, sir, please.
So how do I go about it?
Just click on the share option again.
Share,
And
yes. And then
screen
I
one
screen one,
and share.
then share. So I'll go back. I don't know whether it is not allowing me to go.
Yes, just click once on the presentation.
Sorry?
Just click once on the presentation.
Oh, yeah. Not very good at these things. So see, what happens is basically it is almost a commercial device. Basically, it is uh, for sort of storing the data and for identifying the smell. So there is this sample which contains some odoriferous fluid or some material. So some headspace, as I said in my earlier this thing, there is a thing called headspace is the volume. Let's not get too technical. So sample, some odors are getting emitted. These odors are molecules then come to a sensor. This is the sensor part of the electronic nose. So it will sense, this senses whether it is what kind of an odor it is, whether it is a rose, whether it is a lemon, lime. So the sensor, that typical sensor for the rose will get activated. This sensor is say for lime, it will get activated. It will give the pattern recognition system. It will give it will tell that see this odor that we have given is basically odor of a lime. This odor is of a rose. This odor is of sandalwood. This odor is of something else. So basically, this is almost a, you can say it is used in the commercial industry, in the food industry for basically identifying the odors. It is also coming in the medical field, but it is how does it how do you do it? So basically the breath contains some odors. So basically that can be sort of made to use by this sensor array can sort of uh, sense that smell, and it can send it to the your pattern recognition system and then to your computer. So this is how the it works. I hope I am clear. If there is anything more to be, so I'll go back to the. Okay, my computer, I think.
Thank you very much, Dr. Divya Aggarwal. No more questions. Thank you very much for the presentation, and thank you very much, trainees, for joining us.
Thank you all.